Our next speaker is from the University of Nairobi, Center for Epidemiological Modeling and Analysis, and he will be talking today about elimination studies for the country of Kenya.
Good afternoon, everyone. My name is Brian Juguna, and just to short introduction, which most of us are conversant with, measles is a highly contagious disease, and before the introduction of an effective measles vaccine, virtually everyone experienced measles in their childhood. And so for us here, today I'm going to talk to walk you through a modeling study which looks at measles vaccination strategies elimination in Kenya. And the goal of the study is to look at how we can eliminate measles in Kenya by 2030. And the elimination is clearly defined as the absence of endemic measles virus transmission for greater than 12 months in the presence of surveillance or a high-quality surveillance system. So at around 2010, the World Health Assembly established a goal to eliminate measles in at least 5 WHO regions by 2020, which was actually not met. And so according to the Immunization Agenda 2030, we have a goal of achieving measles elimination in at least 80% of the countries in Africa. And to really achieve this goal, because measles is highly contagious, we need a very high vaccination strategy or vaccination coverage, for both MCV1 and MCV2. MCV1 is the first dose of measles containing vaccination. So according to the immunization agenda, we should have a 95% MCV1 and MCV2 coverage, and the supplementary immunization activities, or SIAs, are meant to help to achieve the 95% coverage for the second dose. The plot on the left just shows us the number of cases that has been reported globally, and we can see the resurgence of measles cases in around 2019, where we had a total of more than 800,000 cases reported, and a lot more which was not reported. So we have a research gap such that even with the presence of a well-performing or effective measles vaccine, we still see transmission of measles in the countries that measles is endemic. And in Kenya, Kenya reports at around 3,000 cases per year, and Kenya is divided into 47 counties. The counties are like decentralized government system. And from what you can see here, this is the MCV1 coverage in Kenya. And what you can see is that most counties are around between 80 to 89% coverage for the MCV1. And this data is obtained from the Kenya Health Integrated System, where the hospital reports the coverage as it is. And this is mirrored on the sub-county levels, where one county usually have several sub-counties. That's the general picture of measles coverage in Kenya MCV1. Now, for the MCV2, we seem to be performing quite poorly, where the highest counties had 80 to 29% coverage of MCV2. And remember, to achieve measles elimination, we need a 95% coverage also for MCV2. And this is mirrored also in the sub-counties, where you see in the northern regions, except in Turkana County, the part there northwestern is Turkana County, where it achieved 95% above, but most sub-counties are below 95. So this maps here just shows us which counties and which sub-counties, which counties achieved the 95% coverage. And from what we can see is most counties actually did not achieve the recommended vaccination coverage, and for MCV1, just several counties. And most of the counties did not actually achieve it continuously over the years. And then for the MCV2, we see that most of them actually, none of the counties actually achieved the measles vaccination coverage of 95%. So the plot here shows the monthly vaccination coverage. It also shows the measles cases and MCV1 and MCV2. So from what we can be able to see from this monthly plot is that in most cases we didn't achieve the 95% coverage. Also, we can be able to see there are some cases where the vaccination coverage goes beyond 100, where the hospital reported it like that because sometimes they may vaccinate more people than they actually expected. So they present it as more than 100%. So just to show us the measles incidence in Kenya, we see some counties which have a very high measles incidence. And remember, because of how contagious it is, this can act like hotspot for measles transmission. And actually, these counties like Turkana and Garissa, if you look at the Kenya Health Demographic Survey for 2022, you'll see that they had very high level of undernutrition because research also reports that undernutrition or vitamin A deficiency also affects the measles vaccine. So our research question here, that was just an introduction or the overview of the measles situation in Kenya. So our research question basically was, what are the optimal vaccination strategies to achieve measles elimination in Kenya by 2030? We have conducted several supplementary immunization activities as can be seen. So to answer this question, we used an agent-based model, or we've been using an agent-based model to answer the question. And the agent-based model is implemented through STARSIM. And basically it was an SER model, but we added some more compartments. And from the plot is that the susceptibles are recruited through birth, where they are protected up to about 9 months. And then after 9 months, you either, because in Kenya, the MCV1 is vaccinated at 9 to 12 months, and MCV2 is vaccinated between 18 to 24 months. So at 9 months, you're either vaccinated, and some people are actually not protected after being vaccinated with the first dose. There is a 15% which do not seroconvert. So they are still unprotected, but there are some who get protected, and even after they get MCV2, they are still protected. So we still have some people who get MCV2 and still are not protected. Then we still have those who do not get vaccinated. So our initial model, we used those parameters as defined, and our results, we divided our results into 3 sections. We had, from the plot, you've seen that there is a lot of heterogeneity in terms of measles coverage and also the measles incidence. So we took an approach where we took counties with lowest measles incidence, moderate, and high. So for the counties which had low measles incidence, we saw that, or the initial models said that the maintenance of 95% coverage of MCV1 would help us reach the county elimination within the 2030 target. We also took for moderate incidence. Kisumu is a county in Kenya, and for this we see that to achieve measles elimination by 2030, we need at least a 95% coverage in MCV1 and at least 80% in MCV2. So this map basically summarizes all the results, where the green counties shows the counties which can achieve measles elimination by 95% coverage only in MCV1 with current immunity. We have those who need also MCV1 95 and MCV2 95. And we have those counties which have a high moderate, which needs both MCV1 and MCV2 and supplementary immunization activities. However, because this is work in development, and as modelers, we understand that as time goes by, you keep on adding model complexity, also going back and seeing where probably you've made a mistake. So we had some assumptions, for example, random contact rates. And from what we all know is that the contact rate depends really on the age. For example, school age children, we have a different contact rates with an adult or an older children. So we still have not put into consideration about that. So we are planning on doing that, and also incorporating other model complexities. So, sorry, what we are currently implementing for now is that under the STARSTEAM model, we realized that the implementation of the vaccination is actually vaccinating everyone in the population, which is quite contrary to the reality, because we usually vaccinate between 9 to 12 for MCV1 and 18 to 24 for MCV2. So we've corrected for that when you are still running the model. And then we have winning immunity for children between 0 to 9 months. We are implementing that. And then we also noticed that some parameters in the model are very sensitive. So we really need to think about them and come up with the best way to define them. For example, the initial immunity, of course, the contact rate, which we will put an age-structured contact rate, and then the initial prevalence parameters. You find that sometimes if you put some initial prevalence, there's no outbreak. So those are some of the parameters we need to take into consideration. Also, the measles is a seasonal disease, where, for example, because it primarily affects children, you find that when there is school terms, you find the measles transmission is high. So we need to account for that. But this is just a seasonal transmission parameter without the school term forcing. But we aim at improving it step by step. So it's a model development in process. So these are just very, very, very preliminary results. And what's on the top left graph is just the population structure in Kenya according to 2019 census, since we're running our model from 2020. So we are putting it so that it can really mirror the reality. And from that, what we are seeing here is the current vaccination strategy. If you have, these are basic preliminary results for now, where you have prevalence on the y-axis and you have years on the x-axis. So after we implement those steps, we really need to calibrate this model to Kenyan data, and also we need to incorporate on the effects of HIV and wasting on developing immunity, because they really affect the measles vaccine. So the conclusion from our preliminary result is that to achieve measles elimination in Kenya, we really need to decentralize the measles elimination strategies, because we've seen that there is a lot of heterogeneity, as I had mentioned earlier, in the vaccinations, the coverage, and also in the incidence. So if we take a one approach, then we will leave other districts out, and they will act as hotspots for measles in the coming years. So after also obtaining the optimal strategies, we need to ask ourselves at which cost, because it's very easy to, for example, advise the Ministry of Health that you need a 95% coverage on this, 95% coverage on this, but probably due to limited resources, it's not achievable. So we need to find out the optimal vaccination strategy, both in terms of eliminating measles and also cost effective, because that really matters. So we also need to evaluate the economic aspect of it. So I'll stop there for today. And this is the wonderful team that has been working on this. From the left, that's Cosmas. We have Dr. Mutono Nyamai. We have Stanley. We have Dr. Jeanette Dawa. We have me there. and that person who joined the photo accidentally. I'll take any questions from now. Thank you for your attention.
Thank you very much. We have time for one or two questions from the audience, if there are any. I can use my mic closer.
Yeah, thank you so much for your good presentation. And actually, I like your comment. You have said we need a uniform approach to eliminate measles. But I saw in your map, Turkana, I think a bit of another county, I'm not sure it was in Garissa, had higher case of measles. So I wonder whether do we need a maybe more county-based approach, or do we do uniform? Because we see, can you show the map? There's a map. Yeah, from the map we see clearly the rates are different across different counties. Yet to advocate for uniform approach. So my question is, we can say it's heterogeneous in terms of counties. Do you think we should do a uniform approach, or do we do a more maybe county-based approach? Thank you.
So I think on my conclusion, that's an important question. Thank you. And I think on my conclusion, I said that we really need a decentralized measles vaccination strategy because of the heterogeneity we are seeing here. So a uniform approach really won't work on this because some counties will be left behind, and then in years to come, they will act as measles hotspot. Remember that the measles outbreak are caused by the accumulation of susceptible population over the years. So that's why, for example, you are seeing Turkana after several years, there's measles insurgence. So from the way we have approached it as low measles incident counties, moderate, and then high, so that we can be able to advise the government or the Ministry of Health that for the low measles incidence counties, these are the optimal strategies, and then for the moderate, and then for the high measles incidence. I hope I've answered your question.
Thank you very much. Thank you for the excellent presentation. We need to move on.